for our UCT-Africa virtual ENT presentation. My name is Hervin. I'm one of the registrars at New Somerset Hospital, as well as a registrar in ENT at UCT. So the topic for my presentation this morning will be on salivary duct stenosis. Consent was obtained from my patient, and all my content is referenced. So my case presentation is of a 50-year-old female patient with no comorbidities, presenting with a 1-year history of intermittent left submandibular and parotid periprandial painful swelling, which resolved typically within 2 days with no specific treatment. She also gave a history of bruxism related to anxiety. On examination, no calculus was palpable, and the ducts were not particularly swollen and tender. The patient was booked for a diagnostic saline endoscopy procedure of the left submandibular and parotid ducts. So this is a video of the saline endoscopy procedure we did. Both the left submandibular and parotid ducts were dilated using probes of increasing diameters and a conical dilator. We used a size 0.8 millimeter saline endoscope to scope both ducts up to the 3rd division. We found circumferential narrowing of both ducts with whitish debris. No calculi were found, and both ducts were flushed with a mixture solution of 4 milligrams dexamethasone in 20 moles of normal saline, and no stenting was done. The patient was discharged the next day on analgesia and mouthwash. She was advised to have a blend diet, and she was reviewed 1 week later, and she was symptom-free. So I will focus my presentation this morning on the management of salivary duct stenosis, that is both parotid and submandibular ducts. Salivary stenosis, or stricture or scar, refers to the pathologic narrowing of a salivary duct. Ductal strictures represent 15 to 25% of obstructive sialadenitis and are the second most common cause of obstructive sialadenitis of the salivary stones. Stenosis tends to occur more commonly in women and usually in the parotid ductal system. Parotid duct stenosis most commonly occurs at the middle and proximal third of the duct. So the parotid is the largest salivary gland and lies within the parotid space, and the parotid duct, which is also known as Tenson's duct, runs parallel to the zygomatic arch, approximately 1.5 centimeters inferior to the arch. It courses superficial to the masseter muscle and then pierces the buccinator muscle as it opens into the oral cavity. Its papilla is near the second upper maxillary molar, and the average length of the duct is 4 to 6 centimeters with an average diameter of 2 to 2.5 millimeters. The papilla is the narrowest portion of the duct and is relatively easy to cannulate when compared with the submandibular duct. However, the masseteric bend, which is a natural curve of the parotid duct around the anterior border of the masseter, can provide a challenge to navigate during endoscopic procedures. The parotid duct is also in close proximity to the buccal branches of the facial nerve that lie lateral to the plane of the duct. The anterior border of the masseter muscle is the line that divides the parotid ductal system into an anterior, that is papilla, to anterior border of masseter, and a posterior zone, that is anterior border to the hilum of the glands. The submandibular duct, or Wharton's duct, courses posteriorly along the inferior aspect of the mylohyoid muscle. And once the duct reaches the posterior edge of the muscle, it usually makes a sharp upward and forward turn as it enters the floor of the mouth region. The turning point anatomic area, as well as the intersection between the lingual nerve and the duct, are important landmarks to look for kinks and strictures. And once in the vicinity of the floor of the mouth, the duct continues its path medial to the sublingual gland and superior to the hypoglossal nerve. The duct passes over and then inferior to the lingual nerve. And the trajectory finally ends when the duct emerges on the sublingual papilla next to the frenulum of the tongue, approximately 1 centimeter behind the inferior incisors. And the average diameter of the duct at its orifice is 0.5 millimeters, but the duct itself has an average diameter of 1.5 millimeters, and it's approximately 40 to 50 millimeters long. There are many classifications by which ductal scar may be described, namely tissue color, consistency, scar location, distance from the ostium, the type, the grade, the extent, and the type of inflammation. The causes of stenosis include chronic sialadenitis, autoimmune disease such as Sjogren's syndrome, radioactive iodine-induced sialadenitis, salivary stones, idiopathic causes, and post-radiation changes. Congenital or traumatic abnormal ductal anatomy can also cause stenosis, and congenital causes include abnormal ductal folds, ductal reflux, or ductal kinks due to enlarged or hypertrophic masseter muscle. Trauma causes can include external trauma, internal trauma, or iatrogenic trauma. Ductal strictures lead to stagnant salivary flow proximally, which results in the formation of mucus plugs that further impede salivary flow. The increased pressure proximal to the plug leads to symptoms of pain and swelling. Resolution of the symptoms occurs when the mucus plug is eventually dislodged and the saliva is released. Obstructive salivary symptoms include intermittent painful swelling of the involved salivary glands with salivary stimulation, and the swelling may be present on waking or before the first meal of the day. Recurrent swelling can result occasionally in recurrent bacterial sialadenitis with purulent discharge, skin erythema, glandular swelling, and fever secondary to sepsis. So in terms of diagnosis, psilography allows the detection of the degree, number, and location of stenosis. And on psilography, stenosis appear as contrast-filled narrow ductal segments or complete filling defects in the ductal system. You can appreciate the stenosis of the left Walton's duct on plain film psilography in the first picture, and on cone beam CT psilography in the second picture. On ultrasound, visualization of a dilated duct distal to a point of blockage and without the presence of a stone is suggestive of ductal stricture. And hypoechoic changes in the gland parenchyma also indicate ductal dilatation. So the picture that you can see is of a right parotid cut with distal stenosis at the papilla and massive proximal dilation of the duct. So the other investigation that we most commonly use is silendoscopy. It has been described as being superior to other diagnostic methods as it allows direct visualization of the ductal system. It allows us to characterize the stricture and as well as therapeutic intervention. Stenosis is identified on endoscopy as a ring or funnel in the duct wall, and strictures may appear as short segments of intraluminal scar or thick mucosal thickening, which may have either a complete blockage or a pinhole lumen. And endoscopically, stenotic areas have increased stiffness of the duct wall in addition to luminal narrowing. The initial treatments of obstructive sialadenitis includes gland massage, hyperhydration, giving sialogogues and antibiotics, and in some cases, oral steroids can be indicated. However, approximately 50% of cases do not respond to these treatments. So, silendoscopy-guided minimal invasive therapy has become the standard of care for the treatment of obstructive sialadenitis, and is currently the treatment of choice for ductal stricture once conservative management has failed. It can be completed under local or general anesthesia, and in comparison to salivary stones, salivary strictures are often more amenable to endoscopic treatment. And this was demonstrated by a study by Gillespie and al. So they did a large retrospective series involving 306 patients, where they found that significantly more non-stone obstructions could be treated with endoscopic approaches alone compared with stones, 77% versus 17%. So usually entering the papilla is the first step to silendoscopy. And if the papilla cannot be identified, every attempt should be made to locate the papilla, and that includes a methylene blue test. So methylene blue is tipped onto the area of the papilla, and the gland is massaged, followed by a slow sweeping of the duct in a distal direction to express a small amount of saliva. And the saliva will lead to some washout effects of methylene blue, and this enables easy detection of the now highlighted papilla. So acute sialadenitis is the only contraindication to silendoscopy. An active inflammation can make the procedure difficult, especially when trying to cannulate the duct. And when using the rigid dilator system or even a semi-rigid endoscope during an acute episode, there is an increase in the risk of ductal trauma, and this can potentially spread infection into the soft tissues. And therefore, it is ideal to let the acute inflammation pass before trying to manage a stone or stricture, and usually 6 weeks is considered adequate. In cases of acute sialadenitis without an obstructive etiology, such as in acute or chronic parotitis or in juvenile recurrent parotitis, Jackson and Walviker have observed in practice that patients in whom conservative management with intravenous antibiotics has not helped in reducing or resolving symptoms within 48 hours, a conservative diagnostic silendoscopy with a washout of intraductal debris can provide symptomatic relief to patients. So I will now address parotid interventions based on specific clinical findings. If the parotid papilla cannot be identified even after a methylene blue test, the safest option is to discontinue the procedure. However, in the presence of a ductal stenosis at the papilla, if it has been established from a preoperative evaluation, Gillespie has described a transoral approach to revise the natural papilla by performing a circumferential incision around the papilla and then stretching the duct, followed by excision of the distal papillary stenosis and creation of a new papilla with or without a salivary duct stent. And if salivary ductal stenting is chosen, the stent is ideally left in place for 6 to 8 weeks. If the papilla is visible and there is a stenosis in the distal parotid duct, it may be possible to dilate the papilla and perform a diagnostic silendoscopy to find a ductal scar that is within 2 centimeters of the papilla. Dilation can be done by either a guide wire placement in the stenosis, followed by dilation using endoscopes of increasing diameter, dilators or metal bougies. And successful dilation can be gauged visually and by the ability to pass a 1.6 millimeter cylindroscope. And following dilation, a salivary duct stent can be placed for 4 to 6 weeks. In a paper published in 2010, Odikian and colleagues followed 87 patients with parotid stenosis who were treated with ductal dilation and steroid irrigation, and they reported an 81.7% success rate. In the case of a ductal stenosis or stricture in the mid-ductal region at a point between the hilum of the gland and proximal to 2 centimeters from the papilla of the parotid duct, it may be possible to use a balloon dilator with endoscopic guidance. Some dilating balloons available do not fit within the interventional channel of the cylindroscope, and these balloons need or can be used in conjunction with ultrasonography to dilate parotid ductal strictures under ultrasound guidance. However, this technique requires ultrasound expertise, and that limits its utility in resource-limited settings. In general, stenoses that occur at the hilum of the parotid gland or in the intraglandular portion of the ductal system are difficult to treat, and dilation with the tip of the salivary endoscope does not allow adequate dilation and does not have sufficient efficacy in terms of long-term benefits. In the case of persistent symptoms, Botox injection of the parotid glands can be performed under ultrasound guidance to reduce salivation and obstructive symptoms. And if this fails, then parotidectomy with facial nerve preservation can be considered. The submandibular duct is identified and dilated similar to the parotid duct. In a combined approach, ductal incision and marsupialization is done, and the neo-ostium is sutured to the floor of the mouth mucosa. And this allows the stenotic portion of the duct to be bypassed or opened. Stent placement into the duct at the termination of the procedure prevents repeated stricture formation by passive dilation and prevents luminal obstruction from post-operative edema. Stents are sutured in place with non-absorbable sutures and remain in place for 2 to 4 weeks post-operatively. Intraductal steroids may be beneficial to prevent fibrotic remodeling cases of inflammatory stenosis. In case of persistent obstructive symptoms following cylindroscopy, submandibular gland excision may be necessary. So interventional cylindroscopy is a safe and low-risk procedure. However, complications can still occur. These are typically secondary to chronic inflammation of the ducts, as well as areas of stenosis. The masseteric band can be difficult to navigate and can potentially be a site of ductal trauma if not managed with external or endoscopic maneuvers to decrease the bend, such as pulling the cheek forward to straighten the ducts or following a guide wire to navigate the scope across the masseteric band. And as you can see, the picture is an endoscopic image of the parotid duct that shows a ductal tear. And the blue arrow points to the tear in the salivary duct. In the event of minor ductal perforation, the procedure should be aborted, irrigation should be stopped, and a repeat endoscopy can be attempted in 4 to 6 weeks. If you have an experienced surgeon who's skilled in cylindroscopy, they may be able to navigate the endoscope beyond the ductal perforation and leave a guide wire in place. The scope can then be replaced by a stent, and usually short-term salivary ductal stenting is recommended depending on the extent of the ductal injury, and that varies from 2 to 4 weeks. So in conclusion, silent endoscopy is the current standard of care for the diagnosis and management of salivary duct stenosis. And the management depends on the location and extent of the stenosis. Treatment can be conservative using silent endoscopy with or without dilation or excision of the glands. These are the references I used for my talk. Thank you very much.
Very nice comprehensive talk there too. I don't have any specific comments from my side that I have since on the call, and I would like to make a few comments.
Dr. Pretorius, do you have any comments?
Well done, Hervin. I think that was a very, very comprehensive talk. Just regarding stenting of stenosis and strictures, I think it's at the moment it's all a bit of a thumbsuck. Everywhere you read different articles and papers, and everybody will tell you to stent different sort of length of time, but there's no consensus at the moment as to what is actually long enough. Is it a week, 2 weeks, 10 days, 4 weeks, 6 weeks? But what keeps on coming up is that most people say that the patient don't tolerate it that well. So some people leave the stent in until the patient pulls it out or it comes out spontaneously. And that normally happens between 1 to 2 weeks time. So that's why I prefer to keep my stent in for a week and then I take it out after a week, and I seem to have short-term success in that regard. But it has been proven, there's a study from New Zealand to show that systemic steroids actually decreases the recurrence rate of stenosis or strictures very, very well. So the discussions, and at the moment, I think where things are headed is drug-eluting stents. So they're looking to develop a drug-eluting steroid stent that you can leave in the duct that obviously then dilutes steroids into the surrounding tissue to prevent restenosis. But it's a very common problem, especially in the background of autoimmune illnesses that are becoming more prevalent. But other than that, thank you very much. I thought it was a very good talk.
Thank you very much.
Just one question for slightly off the topic for yourself or Vincent. We occasionally see Sjogren's syndrome. It can be a bit of a challenge to diagnose, and they often have recurrent silent adenitis, and that's often an indication why we see them. Is the later biopsy when your anti-ROS and anti-LAS still the gold standard, or are they new pathognomonic or diagnostic measures on silent endoscopy?
I've read papers from overseas where they routinely do those tests, but I've never seen them being done here in New Somerset. Maybe Dr. Pretorius, do you have any thoughts?
Yeah, so there aren't clear diagnostic features that are associated with Sjogren's, because you basically still get what you get with recurrent juvenile parotitis. So you get a pale duct, but that's quite stiff. It's got very decrease in pliancy. But if you have to use, it's basically an adjunct to your diagnostic armamentarium. I think the lip biopsy has only got a sensitivity of about 50%. Sensitivity. So I normally take the history, so xerostomia, dry mouth, bilateral gland involvement. I do the silent endoscopy. If I've got typical features, I would also do a minor salivary gland lip biopsy at the same setting. When the patient becomes symptomatic, as in has flares, I think that's the ideal time to then do a blood test, and then your yield is a little bit better.
Are there more?
So, but that's what I do.
Thank you, Dr. Pretorius. Are there any comments from the floor?
You stop sharing. Stop sharing.
Just to add anecdotally, so far, what you read in the literature is that silent endoscopy is not that it's effective for Sjogren's, but not as effective as other obstructive salivary gland diseases when you treat with silent endoscopy. But I must say the patients that we've done with Sjogren's have done very, very well. They go from being symptomatic to a daily or a weekly basis. The one lady from Friedenberg I did a month or 2 months ago hasn't had symptoms now for more than 3 months. So I think there is a place. And then I think also mentioned in my talk at Congress, there's also discussion around recurrent juvenile parotitis and how many patients in the long term, with long-term follow-up, develop Sjogren's disease in adult age, but that hasn't been clearly studied yet.
Thank you very much. Are there any questions or comments from the floor?
Thank you very much. Very good presentation.
Thank you very much, everyone, for attending. Our next talk will be next week on Wednesday. Have a nice day. Thank you.
Well done.